So good evening friends, this is Dr. Vineet Sehgal and welcome to this session which is the continuation of my capsule course in ophthalmology.
This is Dr. Vineet
So
Sehgal
can you hear me everyone? Okay, so this session would be continuation of our session that I was taking in our capsule course for my plus students. So in this session I would be discussing the important questions and the important topics of the retina and its one-liners, which would be also useful for those students who are preparing for the FMGE exam. So in this session we would discuss about the OCT pictures, and specifically we would discuss about the age-related macular degeneration, which is a very common cause of the central blurring of vision in old people. Also in this session I would discuss about few diagnostic techniques, and we would also discuss some basic important points regarding the scleritis and episcleritis. So hope all of you would enjoy this session. Subscribe for the Unacademy PG program with my referral code, that is Dr. Vineet 10. Let's crack it. Okay, so this is a picture of optical coherence tomography. If you can appreciate, can you appreciate this picture? Here, if the black color that you are seeing, this is vitreous, and the layer which is in contact with the vitreous. Dr. Anurag, can you tell me what is this layer which is in contact with the vitreous? So this layer is internal limiting membrane. So we have 10 layers of retina, out of which the layer which basically is in touch with the vitreous humor is the internal limiting membrane, and the hyperreflectile layer. Can you see this hyperreflectile layer, everyone? So this is in contact with choroid. So this is my choroid, and this hyperreflectile white layer that you are seeing, this is a retinal pigment epithelium. Okay, and these are our various 9 layers of the retina, and a small blackish space which you are seeing here, which is very compact, this space is called subretinal space. Okay, I have just written a short form here, subretinal. Is it clear, Dr. Anurag? Okay, so now my first question is identify this spotter: central serous retinopathy, macular hole, cystoid maculoedema, or wet age-related macular degeneration. Try to answer. So if you can appreciate, the 9 layers are intact, but this is my 10th layer, that is retinal pigment epithelium. So between the retinal pigment epithelium and the 9 layers, there is a fluid accumulation. A serous fluid accumulation detaches the 9 layers from the retinal pigment epithelium. Okay, so it is called a foveal detachment, also called Shubham. It is called a central serous retinopathy. So in my plus course, I told you about the various features of central serous retinopathy, like it is seen in type A individuals who are very anxious. It is also seen with those individuals who are having use of steroids, and the pregnancy and the tuberculosis, they are also the risk factors for central serous retinopathy. So basically, how to identify in OCT? There is a clear fluid between the 9 layers and the 10th layer of retinal pigment epithelium. Okay, so this is the subretinal fluid which is accumulated in this space beneath the neurosensory retina, beneath the 9 layers of the retina, and above the retinal pigment epithelium layer. Okay, so this is the next question. Identify the spotter: central serous retinopathy, macular hole, cystoid maculoedema, or wet age-related macular degeneration. Try to answer. Now if you can appreciate here, the layer Remember, foveola is a very thin layer of the retina, or you can say it is the thinnest part of retina. At this pathology, if you can appreciate, all the layers are basically absent at the foveola. So there is total loss of the layers of retina at this place. So what is this called? This is called a macular hole. Okay, usual cause is either idiopathic, or it can be due to trauma, or it can be after a cystoid macular edema. So basically, if you can appreciate, at the level of macula, at the center of the macula, some layers are absent. So this is called macular hole. Now I am showing you again the picture of central serous retinopathy. This is CSR and this is macular hole. So Sneha, now is it clear how the two differs from each other? Okay. So now the third spotter is, identify this spotter: central serous retinopathy, macular hole, cystoid maculoedema, or wet age-related macular degeneration. So if you can appreciate here, there are also cystic spaces. Cystic spaces are seen in the inner part of the retina. So if you can see, cystic spaces are seen in inner layers of the retina. Unlike a central serous retinopathy, where the 9 layers of the retina, that is the neurosensory retina, that is absolutely normal. In cystoid maculoedema, the inner layers have edema. Okay, so this is basically a cystoid maculoedema. Remember, cystoid maculoedema, a very important mnemonic. The drugs that cause cystoid maculoedema, that is NEET PG. So many times it is asked in the exam, what are the drugs that can cause a cystoid maculoedema? So N, can anyone tell me what is N here? Many times I told you the mnemonic. N is your nicotinic acid or your niacin. What is E here? E is epinephrine. Okay, so double E is consumed here. What is T here? T is tamoxifen. What is PG here? PG is PG analogs, which we use in the treatment of glaucoma. Okay, so these are the important drugs which can cause a cystoid macular edema. The most common cause is after a intraocular surgery. It can be also there in a diabetic retinopathy or a vascular occlusion like central retinal vascular occlusion, venous occlusion. Okay, and few drugs can also cause it. I have told you the name of the drugs: NEET PG, nicotinic acid, epinephrine, tamoxifen, and PG analogs. Okay, now I come to the topic of the day. So identify this spotter: central serous retinopathy, macular hole, cystoid maculoedema, or dry age-related macular degeneration. Try to answer. If you can appreciate here, that in this case you are seeing some yellowish spots at the level of macula. If you can appreciate, these yellowish spots are in this region only. Otherwise, your retina seems to be normal. Okay, so what is this? This is a dry age-related macular degeneration. How you can differentiate that this is a drusen and not a hard exudate? Remember, in dry AMD, you see the characteristic appearance that is called drusen. So DR goes with DR. Remember, whenever there is a drusen, let's say this is my OCT. So drusen is lipohyaline deposition beneath means below the retinal pigment epithelium. So if you can appreciate here, can you see? I just move my head from here. If you can see here, this place, Everyone give me a thumbs up if you can see here. So there is a elevation of RPE. If you can see my cursor, this orangish, yellowish orangish layer is called retinal pigment epithelium. So Dr. Sneha, if you can see, this RPE is elevated. So something is going on beneath the RPE. Okay. So if the lesion is beneath the RP, and this is a yellowish type of lesion like this, which has discrete margins. Okay. So hard exudates also definitely look like this. But your OCT can tell whether it is a hard exudate or it is a drusen. If it is a hard exudate, it is seen in the diseases like diabetes. Okay. If it is a drusen, it is seen in dry ARMD. Is it clear, Dr. Anurag? So do not confuse a drusen of a dry ARMD with hard exudates of a diabetic retinopathy, or it can be in central retinal venous occlusion. Both have distinct margins, but a drusen is beneath the RP and the hard exudates are there in the inner layers of the retina. Is it clear? Okay. So the next thing is wet ARMD. So we have two types of age-related macular degeneration. Remember, whenever the macula is involved, the main symptom of the patient is, the patient says, sir, I am having central blurring of vision. Okay, like in retinal detachment, I told you what is the main symptom there. The patient comes with curtain falling over the field of vision. In ARMD, patient comes with central loss of vision. Plus, the patient says, sir, I am not able to see the shape of the object clearly. What is this term called? Can anyone tell? If the patient is not able to identify the shapes clearly, we call it metamorphosia. Okay. Then your color vision and contrast, they also are basically hampered. So remember, a wet ARMD and dry ARMD both can cause metamorphosia, color and contrast sensitivity loss. Or you can say any disorder which is basically affecting macula can cause this. Okay. So the wet ARMD, which is also called choroidal neovascular membrane. Okay. So like in diabetic retinopathy, you get new vessels. Similarly, in choroidal neovascular membrane, you get new vessels in the choroidal region. Can you appreciate this scar? Everyone, give me a thumbs up. So Abhinaya, if you can appreciate, there is a scar here, the hyperpigmented scar you are seeing. Do not confuse it with the dry ARMD where you are seeing the drusens. So you are seeing yellowish structures in the dry ARMD and you are seeing a scar, reddish blackish scar at the level of the macula in wet ARMD. Okay, and if you can appreciate here, there also, this is your retinal pigment epithelium. Dr. Anurag, can you appreciate here? This is your retinal pigment epithelium. Here also it is elevated. Okay, so it is elevated both in dry RMD and in wet RMD. Dry RMD, it is because of the lipohyaline material, and in wet RMD, it is because of the new vessels that are formed beneath the retinal pigment epithelium, which is also called choroidal neovascular membrane. So whether these are new vessels or not, so you would ask me, sir, if they give only OCT picture, can you identify whether it is a dry RMD or it is wet RMD? So at your level, at UG level, it is very difficult to basically identify dry or wet RMD just on the basis of your OCT. So the new vessels, you need the angiography, which is called fluorescein angiography, and if these vessels are beneath the RPE and very localized, you can use another technique which is called ICG. Can anyone tell me what is the full form of ICG? So one thing that you have to remember is that ICG angiography is specific for choroidal disorders. Okay, and the full form of ICG is, very good Dr. Abhinaya, it is indocyanine green angiography. Okay, so this is WetAMD. Now I would show you a flow chart how the WetAMD becomes. So the new vessels grow behind the macula. They break the Bruch membrane. So Bruch membrane is the layer of the choroid which is in touch with the retinal pigment epithelium. Okay, so I write it here. The Bruch membrane is the layer of choroid which is in touch with the retinal pigment epithelium. Now this, when they break down, these blood vessels which are formed like neovascularization, these are very fragile vessels and they leak blood and fluid at the level of macula, which can cause bleeding and scarring at the level of macula. So this is called a wet ARMD. Is it clear to everyone? Give me a thumbs up. Any doubts? I can repeat it again. So if you can appreciate here, there is a scar formation at the level of the macula. Okay, so this is the macula. This region is called the macula and you are seeing the scar formation at the level of macula because of the new vessels that are formed there. Okay, so I told you about the wet ARMD. Remember, the dry ARMD does not have any treatment. You can just give some multivitamins there, lutein, zeaxanthin, etc. But there is not much treatment possible. But the basic advantage with dry ARMD is it does not cause total loss of vision. So it does not cause blindness. But the wet ARMD can cause the blindness in a person. So wet ARMD, though it is less common as compared to dry ARMD, but still it is more lethal or more visually debilitating. Is it clear, Anurag? Okay. So the wet ARMD is basically divided into three forms: extrafoveal, juxtafoveal and subfoveal. What is the meaning of extrafoveal, juxtafoveal and subfoveal? So subfoveal, if you can appreciate here, in the center of fovea, the vessels are beneath the center of the foveal avascular zone. So if you can appreciate, if this is my fovea, is it clear, Abhinaya, Dr. Anurag, everyone, Sneha? So if my new vessels are directly here, formed here, this is called subfoveal. Okay, so it is at the most critical area, that is subfoveal. Okay, then we have juxtafoveal. So juxtafoveal, what means that it is a bit far away from the center of the macula. So let's say this is a bit far away from the center of the macula. And the third one is extrafoveal, which is more further away from the fovea. So the distance, whether it is 200, 250, 100, 150, you do not need to remember that for your UG exam. But here you have to remember that one thing is, so Anurag, you can just do something which is refresh this page and then I think the video correlation can occur. So what I can tell you is that in these conditions, in extrafoveal, the scarring or the new vessels are further away from your fovea. Okay, so can you tell me which type of wet ARMD? So we have three types: subfoveal, juxtafoveal or extrafoveal. So which type of ARMD is most serious or most dangerous to the patient? Can you answer? So we have juxtafoveal, extrafoveal, subfoveal. Which one is the most dangerous for the patient? So the most dangerous for the patient is which is most near the center of the macula. So subfoveal is most dangerous for the patient. Is it clear, Dr. Anurag, Dr. Binaya? Okay. Now, what are the treatment options for this type of ARMD? So we have two treatment options. One is photodynamic therapy, okay, and the other is anti-VEGF injections. First, we would talk about the photodynamic therapy. So the photodynamic therapy uses a light sensitive dye. And can you tell me the name of the light sensitive dye? So it is vertipofrin or rostopofrin. Vertipofrin is the most commonly asked question. So if they ask photodynamic therapy is used in which disease? So your answer would be photodynamic therapy is used in subfoveal wet ARMD. So what happens in photodynamic therapy? You give this dye from your veins and this dye then accumulates in your blood vessels. It preferably accumulates in the new vessels that are formed. So let's say if the patient is having new vessels beneath the fovea. Is it clear? So if the new vessels are beneath the fovea, these vertipofrin dye is basically accumulated there. The patient is kept in a dark room, and with the help of camera, we definitely see where are the vessels where this dye is accumulated. So we can see what are the normal vessels and what are the abnormal new vessels. And when the abnormal new vessels are seen, we can photocoagulate them. Okay. So what is the laser we use? The laser we use is diode laser. Okay, 689 nanometer diode laser. So how this basically works? This laser basically then coagulates the new capillaries. So the leakage and the blood that is basically extravasating from these new vessels is now controlled. Is it clear, Anurag, Dr. Binaya, Dr. Sneha? So this is basically called a photodynamic therapy. For those students who have just joined now, I am repeating again, photodynamic therapy is used in subfoveal wet ARMD, where we use vertipofrin dye and diode laser to basically coagulate the new blood vessels. So the next question is, what is the test used for home monitoring of ARMD patients? Your options are modified Amsler Dubois retinal chart, Hess chart, Maddox rod test, Amsler grid chart. Try to answer. So the answer here is Amsler grid chart. I told you that whenever there is a ARMD, the age-related macular degeneration, patient would be having issues with seeing the central objects. Also, he would not be able to identify the shape of the various objects. So if you can see here, there is a large square and in between them there are many small squares. So we tell the patient to see the large square ones and then you see the small squares at the center of the small square. If the patient says that earlier he was able to see the shape of all the squares without any scotoma in between, this means the patient is normal. But if the patient says that now I am not able to see the squares or the shape is not visible to me, this means there is a progression of ARMD. Let's see, he say a scotoma here. So scotoma means he see a total black here. He is not able to see the central squares. Earlier this was not there. So this is basically progression of the macular degeneration. Is it clear, Dr. Anmol? Okay. So what is the modified Amsler Dubois retinal chart? If you can see this picture. So when we are residents and we see a patient, then in our rounds, what we do is that we do an indirect ophthalmoscopy, see various lesions. If you can see here, this is the optic nerve head, this is the macula. The various colors which you are seeing, let's say the blue color that you are seeing here, this is the retinal detachment. Okay, the red color that you are seeing, this is the neovascularization. The blackish color pigmented lines you are seeing, this is the lattices. You do not have to go into details of what every color means, but remember only one thing, that the blue means retinal detachment. Okay, so the blue means retinal detachment. This is your red color. The red color is your this is your red color, that is hemorrhage, and this is your blue color, which is basically your retinal detachment. Is it clear, everyone? Okay. So the third option was Hess chart. If you can appreciate, this is a Hess chart. And here, if you can see in the left eye and the right eye, the black lines you are seeing, this is basically how much is your extraocular muscles acting here. Okay. So in right eye, you can see all the, so basically the right eye, you see here all the lines here. So basically all the lines, if you are seeing here, this means that your all the extraocular muscles are working very nice. But if the left eye is here, if you can appreciate, Dr. Preeti, that in left eye, these black lines, if you can see the black lines, they are at a very small quadrant. So there is a restriction of movement of our left eye extraocular muscles. So my right eye extraocular muscles, they are basically normal. In my left eye, the extraocular muscles are restricted. So what is the use of Hess chart? The Hess chart is basically used to see the action of extraocular muscles. So any paralytic squint, there is a, if there is a paralytic squint, you can use this Hess chart to see whether there is a muscle which is acting or whether there is a muscle which is not acting. Now the next cheese is Episcleritis. So we have done about the ARMD, how to measure the ARMD. Now we would talk about the Episcleritis. So when I told you about the various layers of the eyeball, so the layer which is at the top is sclera. Remember, sclera itself is basically covered by the conjunctiva. Okay, sclera itself is covered by the conjunctiva, and in between the conjunctiva and the sclera, in between the conjunctiva and the sclera, the tissue that is there, can anyone tell me what is this tissue called? Beneath the conjunctiva and sclera, what is this called? So this is your conjunctiva and this is your sclera. What is this tissue called? So remember, this tissue which is between the conjunctiva and sclera, this is basically called Tennant's capsule. So what is exactly a episcleritis? Epi means above, the sclera having inflammation. So we have inflammation of Tennant's capsule, that is called episcleritis. Okay, so here the superficial vessels are involved. It is more commonly seen in females, where their causes can be either idiopathic or the autoimmune diseases like gout, rosacea, or infective diseases like herpes zoster, syphilis, Lyme disease. Remember, two very important points that are asked regarding the episcleritis. What is the treatment of episcleritis? This was a previous year NEET question. So the episcleritis, the main thing is you do not have to treat the patient. You just have to counsel the patient that it is self-limiting. Okay? If the patient has pain, you can just give a painkiller, but there is no need of steroids or immunosuppressants to be given in this patient. There are not much ocular complications that can occur in scleritis. Is it clear, Dr. Preet? Okay. So is that what you wanted to know? Okay. So the second thing is scleritis. So remember, when we have episcleritis, the next thing we have scleritis. It is also more common in females. It is less common than episcleritis. Like your episcleritis, it is also associated with various autoimmune disorders. But the most common autoimmune disorder which is associated with scleritis, can anyone answer? Most common autoimmune disorder. It is rheumatoid arthritis. Okay. So here the sclera is involved and the deep vessels which are around the sclera, that are basically involved. It is basically a more complicated disease, because when the inflammation is in sclera and the sclera can basically melt down, then this infection can go inside the eye and there can be perforation of sclera. You get my point, Dr. Preet, Dr. Anurag? So basically a perforation of sclera, a thinning of sclera can occur there, and from that there can be uveal tissue which can protrude through that. So that if the uveal tissue protrude from the sclera, what is this condition called? Can you tell, Dr. Preet, Dr. Anurag? If the uveal tissue protrudes from the sclera, this is basically called, have you heard the name of the term? Staphyloma. Okay, so for complicated to the scleritis, there can be a staphyloma which can also predispose there. Okay, so that's why scleritis is more significant disease and it needs treatment. As I told you, most commonly scleritis is because of the autoimmune disorders. So here we have to use the systemic oral corticosteroids or oral immunosuppressants. If you cannot give the immunosuppressants or corticosteroids, at least you start with the indomethacin so that the inflammation process is reduced. Okay, so this is the basic difference between the episcleritis and scleritis. In scleritis, it is more complicated, deeper plexus are involved, and in episcleritis, it is self-limiting disease where the superficial tenon capsule only is involved. Okay, so last but not the least, the question was asked regarding the blue sclera. So the blue sclera is that normally what you see from the transparent conjunctiva, you see a white sclera. If this white sclera is not there, there is a bluish tinge coming there, then the differential diagnosis can be osteogenesis imperfecta, premature infants, Ehlers-Danlos syndrome, pseudoxanthoma elasticum, or alkaptonuria. So there are a lot of causes, but these causes, osteogenesis imperfecta, premature infants, Ehlers-Danlos syndrome, pseudoxanthoma elasticum, and alkaptonuria, they are the basic causes of a blue sclera, and this was a previous year All India question. Okay, so here we complete our retina session of the FMG and also for the NEET exam. Still, if you have any doubts, you can ask personally to me in the Unacademy Telegram app, or the Plus students can ask me in the Ophthalmology app also. Subscribe for the Unacademy program with the code that is Dr. Vineet 10. Let's crack it. Thank you very much for attending the session.